Imagine you are a registrar in a busy community clinic, and a patient sits down in front of you.
Right.
Let's call him Arthur. So Arthur is presenting with severe major depressive disorder, but he also has a severe active alcohol use disorder.
Which he's likely using to self-medicate, I imagine.
Exactly. And due to years of really poor self-care, he has a highly unstable cardiovascular condition as well.
That is a very complex but very realistic presentation.
It is, yeah. So if you go to your shelf and you just blindly follow the official gold standard medical rulebook for major depression.
Right, the siloed guideline.
Yeah, and then you cross-reference it with the official rulebook for alcohol withdrawal and then stack that on top of his cardiologist's rulebook. I mean, the combination of interventions you might prescribe could mathematically contradict.
Absolutely. You could cause a fatal arrhythmia. You could legally kill him.
Which is terrifying. So, welcome to this highly tailored deep dive. Today, we are embarking on a conceptual synthesis of practice guidelines in modern psychiatry.
We've really designed this session specifically for you. You know, the clinician, the trainee, the motivated student.
Yeah, it's meant to serve as a companion to your reading of the clinical literature.
Spot on.
Yeah.
We aren't here to just read a list of bullet points. You can read the primary text on your own time. Our goal here is to build robust mental models.
Right, to clarify the underlying mechanisms of how these guidelines are actually forged.
Exactly. And ultimately, to strengthen your clinical reasoning when you are actually sitting in the room with someone like Arthur.
And to really ground this entire discussion, I think we need to explicitly state the foundation of what we are dealing with here.
Which is the definition of psychiatry itself.
Yes. Psychiatry at its core is the study of how brain, mind, and experience interact, and how that process can go wrong.
Is a profoundly complex field. And, you know, it's often very ambiguous.
Very. And because of that ambiguity, I think we sometimes look at clinical practice guidelines with a profound sense of trepidation.
Which is entirely understandable, frankly. There is this very common, very pervasive fear among clinicians that practice guidelines are essentially railway tracks.
Oh, railway tracks, right.
Yeah, rigid, predetermined paths.
The fear that once you are on the track, you cannot deviate. You cannot steer at all.
Exactly. That you are forced into this reductionist, algorithmic sort of cookbook medicine that completely ignores the surrounding landscape of the patient's actual life.
But, I mean, that is a fundamental misunderstanding of what a high-quality practice guideline actually is, or at least what it's engineered to be, right?
Right. We need to shift that metaphor entirely. True practice guidelines are not railway tracks. They are a compass.
I really want to hold on to that, a compass.
Yeah, think about what a compass actually does. It provides a scientifically verified heading.
Mm-hmm.
It is calibrated based on the absolute best available evidence, pointing you toward true north for a specific isolated condition.
Right.
But, and this is where the art of medicine really comes in, it still requires the clinician to navigate the unique, rugged, and often very unpredictable terrain of the individual patient.
Because the compass doesn't walk the path for you.
Exactly. You still have to account for the comorbidities, the physiological contraindications, the cultural context, their personal values. The compass just stops you from wandering aimlessly into the wilderness.
That sets the stakes perfectly, I think, because over the last half-century, our knowledge of mental illness, the etiology, the epidemiology, the psychopharmacology, it has absolutely exploded.
It's unrecognizable compared to 50 years ago.
We have functional neuroimaging. We understand receptor affinities in ways that would have seemed like complete science fiction.
Oh, absolutely.
Yet when you look at the epidemiological studies, there is this really disturbing reality. Effective evidence-based interventions are frequently delayed by years before being offered to patients.
Or worse, they are never implemented at all.
Right. Why is that?
Well, it is a massive translational gap, the gap between scientific advancement and day-to-day patient care.
Mm-hmm.
We have these brilliant, rigorous RCTs happening in isolation. But if a clinician in a rural clinic isn't rapidly integrating that data, the research doesn't actually help the patient.
So practice guidelines exist specifically to bridge that gap.
Yes, they are the translation engine.
But before we can confidently use this compass out in the field, we need to understand how the compass was actually built. We need to trace the evolution of evidence.
Where we started, essentially.
Right. Where is the historical baseline here? When did psychiatry first try to standardize care? Because I imagine it wasn't always, double-blind placebo trials.
Oh, it certainly was. The earliest attempts at psychiatric standardization in the United States, for example, go back much further than most people realize. We're looking at 1851.
Wait, 1851, pre-Civil War.
Yes.
I mean, we barely had germ theory, let alone a unified theory of the mind.
Exactly. The group was the American Association of Medical Superintendents of Hospitals for the Insane. They were the precursor to the modern American Psychiatric Association.
Okay.
In 1851, they issued 26 propositions. But what is fascinating is the actual content. They weren't proposing clinical interventions.
So no early psychotherapies or anything?
No chemical restraints or therapies. They were essentially architectural guidelines.
Architectural.
Yeah, they were about the physical construction of hospitals for the insane. Things like ventilation, the exact ratio of patients to attendants, the use of the Kirkbride plan with its staggered layouts to maximize sunlight.
So the very first psychiatric guidelines were basically building codes.
Yes, essentially.
Yeah, right.
2 years later, they published 14 more propositions concerning the administrative organization of these facilities.
Right.
But here is the vital distinction for understanding the evolution of evidence. Those early propositions lacked any documented methodology. There was absolutely no transparent development process.
They're just based purely on authority then.
Pure.
It was the sort of word-of-mouth family recipe era of medicine. A group of esteemed, wealthy superintendents gather in a mahogany-lined room, decide what they think is best based on their own anecdotal experiences, and declare it the unquestionable standard.
That's a great way to put it. Trust me, this is how you build an asylum, because I've built 3 of them.
Right. No peer review, no data control, no dissenting opinions allowed.
Precisely. It was standardization by eminence rather than standardization by evidence.
Mm-hmm.
And frankly, for a long time, much of medical standardization across all specialties looked exactly like that. It wasn't until the late 1980s that we saw a massive structural shift towards true rigor.
Ah, right. When the American Medical Association, the AMA, finally convened a group of representatives.
Yes, from 14 medical specialty organizations, including the APA, they formed the Practice Parameter Partnership.
And the goal there was to establish the ground rules for what a guideline should actually be.
Exactly. And then the Institute of Medicine, the IOM, steps in around 1990 with a landmark monograph.
Right. They looked at this chaotic landscape of competing specialty guidelines and essentially said, we need a universal definition for what makes a guideline good.
They did.
Yeah.
The 1990 IOM report defined the good guideline through 8 essential attributes, and these really became the gold standard for clinical engineering.
What were they?
They are validity, reliability or reproducibility, clinical applicability, clinical flexibility, clarity, multidisciplinary process, scheduled review, and documentation.
Okay, let's dig into one of those to really show the contrast with those 1851 asylum rules. Reliability and reproducibility. What does that actually demand in the context of writing a modern psychiatric guideline?
It is a phenomenal, highly rigorous concept. It demands that if you take a completely different group of guideline developers...
Like a completely different set of psychiatrists and statisticians.
Exactly. And you hand them the exact same body of evidence, the exact same stack of research papers, and instruct them to use the same evaluative methods. They should arrive at the exact same clinical recommendations.
Oh, wow. So it completely neuters the guru factor.
Yes. It's no longer about the brilliant intuition of Professor Smith or Dr. Jones dominating a committee room.
It transforms the family recipe into a peer-reviewed chemical formula. The data just has to lead inevitably to the conclusion, regardless of who is doing the maths.
That is the goal. But, as your analogy suggests, even if you have a perfect chemical formula, things can still go quite wrong in the laboratory of the real world.
Which leads me to a massive pushback. If this 1990 IOM framework was so rigorous, and if we supposedly cracked the code on making these perfectly reproducible guidelines,
Right.
why did the IOM have to release subsequent highly critical reports in 2008 and 2011? They pointed out that guidelines still weren't fulfilling their promise. If the maths was perfect, what went wrong?
It is a crucial question. The 2008 IOM report, titled Knowing What Works in Healthcare, was a necessary course correction. The problem wasn't that the 1990 ideals were wrong.
Okay.
The problem was the landscape of modern medicine had fundamentally changed, and the execution was, well, flawed. First, there was unprecedented information overload.
Just too many studies.
The sheer volume of medical literature was growing exponentially, making comprehensive reviews nearly impossible without massive infrastructure. Second, There were huge subjective variations in how different groups appraised evidence.
Oh, I see. One group's definitive proof was another group's methodologically flawed pilot study.
Exactly. So reproducibility was failing because the grading scales themselves were completely subjective.
Yeah.
But third, and this was the dark cloud hanging over the entire medical field at the time, there was inconsistent, often negligent handling of conflicts of interest.
The pharmaceutical money. Big pharma.
Yes. If a pharmaceutical company is quietly funding the administrative costs of guideline development, or if the expert panel writing the guideline receives significant speaking fees from the manufacturer whose drug is being elevated to a first-line treatment.
Then the public and the profession instantly lose trust in that compass, and rightly so.
Absolutely. You cannot trust a compass if the needle is bought and paid for.
So how did the IOM fix a compass that was fundamentally magnetized by outside financial forces?
This led to the 2011 IOM reports, which demanded draconian new standards. They laid out 21 highly specific recommendations for systematic reviews and 8 recommendations for what they called trustworthy guidelines.
Trustworthy.
Yes, they demanded absolute transparency, public input at multiple structural steps, and the rigorous public management of bias.
Right.
They insisted that the strength of a recommendation must be explicitly mathematically tied to the underlying quality of the available evidence. No more intuitive leaps.
Knowing these incredibly strict engineering requirements, how does a modern psychiatric association actually forge these guidelines from raw, chaotic data? Let's move into the mechanisms and models of development.
Historically, credit goes to the Royal Australian and New Zealand College of Psychiatrists, the RANCCP. They pioneered the integration of research and clinical consensus way back in 1981. But looking closely at the American Psychiatric Association, their modern project began in 1989. And from the very beginning, they established a foundational rule regarding that financial bias we just discussed.
Wait, let me guess. They mandate that industry funding can only make up a certain, small percentage of the operational budget.
No, absolutely no. Industry money is sought or accepted. Zero.
Zero. Practically speaking, how is that even possible? Pharmaceutical companies fund almost all major drug research.
They do.
If you cut out industry funding entirely, how do you pay for the massive logistical effort of an international systematic review?
The association funds it internally through member dues, publications, and independent grants. It is a massive operational and financial hurdle, yes, but it is considered an existential requirement for trust.
Wow.
Furthermore, individual writing group members are subjected to exhaustive screening for potential conflicts of interest. If you hold significant stock in a company whose drug is under review, you aren't writing the recommendation for that drug, period.
Okay, so assuming you assemble this perfectly unbiased, highly vetted team, how do they actually choose what to write about? I mean, they can't just pick their favorite niche research interests, right?
No, the Committee on Practice Guidelines selects topics based on public health significance. They look for high clinical prevalence and high morbidity or mortality.
Right.
They also pragmatically look for areas where there is actually a substantial body of evidence to evaluate.
Right.
Initially, they use the diagnostic architecture we are all familiar with, writing guidelines for specific illnesses like schizophrenia or panic disorder.
Like single disease silos.
Exactly.
Yeah.
But more recently, they've recognized the need for cross-cutting clinical topics. For instance, the use of antipsychotics across various diagnoses or managing acute agitation, regardless of the underlying pathology.
Okay, so the topic is chosen, let's say the treatment of acute schizophrenia.
Yeah.
How does the systematic review process actually function? I assume it starts with the literature search, obviously, mining Medline, PsycInfo, the Cochrane databases.
Yes.
But anyone can type keywords into a database.
True. But this search protocol must be explicitly delineated and published. If a clinician wants to audit the guideline, they should be able to see the exact Boolean operators used, the date ranges, and the strict inclusion criteria.
Right.
But finding the papers is just data collection.
Yeah.
The heavy lifting, the actual science of guideline development, is the granular grading of the individual studies. You do not just read the abstract and look at the p-value, you dissect the methodology.
Yeah, when you look at the methodology section on evaluating evidence in the text, it reads like a forensic audit. The reviewers aren't just looking for good studies.
No, they are actively hunting for bias. Selection bias, performance bias, attrition bias, detection bias, and reporting bias.
Let's ground this a bit. Walk us through what these actually look like in a psychiatric context, because this is where bad science slips through, isn't it? Let's start with selection bias.
Gladly. Selection bias asks, Were the two groups in the study fundamentally different before the intervention even started?
Yep.
Imagine an RCT for a new rapid-acting antidepressant. If, by sheer chance or just poor randomization, your treatment group happens to be significantly younger and has fewer medical comorbidities than your placebo-controlled group, your results are instantly skewed.
Ah, because the younger, healthier group was more likely to recover quickly anyway, regardless of the drug.
Exactly. Next is performance bias. This occurs if the care provided to the groups differs in ways other than the specific intervention being studied.
What does that look like?
Well, for example, if researchers are unconsciously more enthusiastic or spend an extra 10 minutes chatting with the patients they know are getting the exciting new therapy.
Oh, I see. That extra human connection might be driving the improvement, not the molecule itself.
Spot on. And what about attrition bias? I know this is a massive issue in psychiatric literature.
Oh, attrition bias. That's about who drops out, right?
Yes. It is arguably the most insidious. Attrition bias is about who drops out of the study and why. Let's say you are testing a novel antipsychotic. You start with 100 patients. Over 12 weeks, 40 of them drop out because the medication causes intolerable rapid weight gain and severe lethargy.
Which happens a lot.
It does. Now, if the researchers only run their final statistical analysis on the 60 completers who happen to tolerate the drug well, they're wildly overestimating the drug's effectiveness and burying its severe harms.
It creates a sort of false miracle drug.
Exactly. Reviewers hunting for attrition bias will flag that study immediately.
Then we have detection bias, which is about the blinding of the outcome assessors. Like, did the person rating the severity of the depression know which pill the patient was taking?
Yes. Exactly.
And finally, reporting bias. This is the classic. Did the researchers run 20 different statistical tests, find only one positive correlation, publish that one, and quietly file the 19 negative results in a desk drawer?
Exactly. It is a forensic gauntlet. A study has to survive all of those checks just to be considered valid evidence. But grading individual studies is really only step one.
Right. Step 2 is grading the overall supporting body of research. When you aggregate all 50 studies on a topic, how strong is the total evidence?
And here is where we encounter a massive, fundamental misconception in clinical practice about what strength of evidence actually means.
Yes. Because people intuitively assume that strong evidence means the treatment has a massive, miraculous clinical effect on the patient.
Right.
That a strong recommendation means, this drug cures everyone. But that is entirely wrong, isn't it?
It is entirely wrong. Strength of research evidence has absolutely nothing to do with the size of the clinical effect.
Yeah.
It refers exclusively to our confidence that future studies will not overturn the current conclusion.
Let me just make sure that is crystal clear for the listener. You could have a treatment that only provides very mild marginal improvement, a tiny statistical effect size. But if we have 50 rigorous, double-blind, multi-center, placebo-controlled trials that all consistently prove that exact same tiny improvement, we have high strength of evidence for it.
Precisely. The strength rating is about epistemological certainty. It involves assessing the consistency of findings across multiple independent studies, the directness of the evidence, the precision of the statistical estimates, and the overall risk of bias we just discussed.
Now, looking at this incredibly strict, mathematically rigorous process, I do have a major pushback.
Go on.
This framework works beautifully if you are studying a statin for cholesterol or a beta blocker. You give half the people the pill, half the placebo, and you measure the lipid panel. Simple.
Right.
But psychiatric research has profound, unique obstacles compared to internal medicine.
It does. And this is the central friction point in psychiatric guideline development. The rules demand randomized controlled trials, or RCTs, which are the gold standard of medical evidence. But psychiatric RCTs are incredibly difficult and wildly expensive to run.
Oh, sure. Right.
Because of funding limitations, psychiatric RCTs are often shockingly short. We are frequently looking at trials that only last 6 to 12 weeks.
Which is clinically absurd when you consider that conditions like schizophrenia, bipolar disorder, or chronic PTSD are lifelong fluctuating conditions.
Absolutely.
A 6-week snapshot tells you if a drug provides acute stabilization. It tells you absolutely nothing about long-term recovery, relapse prevention, or their functional trajectory over a decade.
Furthermore, and perhaps more importantly, RCT methodology is heavily skewed towards pharmacotherapy.
Ah, of course.
It is relatively straightforward to manufacture an inert placebo pill.
Yeah.
But how do you construct a double-blind placebo for a complex psychological intervention like psychodynamic psychotherapy?
Or a social therapy like supported employment.
Exactly.
You can't. I mean, you can't double-blind a therapeutic alliance.
Yeah.
The therapist knows they are doing therapy, and the patient knows they are talking to a human being.
Right.
So if the strict IOM rules require rigorous RCT data, but the reality of psychiatry means RCTs can't effectively measure crucial psychological interventions, what do? We can't just leave psychotherapy out of the guidelines, or the compass will only point to the pharmacy.
Exactly. This was a critical methodological crisis.
Yeah.
To fill the gaps where RCTs fail or simply cannot exist, the field had to pioneer a methodology to rigorously capture and quantify expert clinical consensus.
And how do they do that?
They use what is called a snowball sampling methodology combined with a modified Delphi process.
Now, wait. If we lack hard data, isn't expert consensus just a polite academic way of saying what the popular doctors think?
I know how it sounds.
Didn't we just spend 20 minutes talking about how we aggressively moved away from the 1851 model of trust the esteemed superintendents? Aren't we just regressing to standardization by eminence?
It is a vital critique, and is a tension the developers are intensely aware of.
Oh.
But here's the defense, and it relies on strict methodological boundaries. First, consensus never overrides solid data.
Okay.
If the RCT data says intervention X is ineffective, the experts cannot vote to recommend intervention X based on clinical experience. Consensus is exclusively used to bridge the gaps where empirical data cannot exist.
Give me an example of a gap where data cannot exist.
Obtaining a thorough psychiatric history.
Ah.
It is universally recognized as the bedrock of psychiatric care. But you cannot run an RCT where half the psychiatrists take a comprehensive history and the control group is strictly forbidden from asking the patient any questions about their past.
Because it's deeply unethical and clinically absurd.
Exactly. You will never have an RCT proving that taking a history is effective.
Yeah.
So consensus fills that necessary, obvious void.
Okay, that makes sense. But how do you prevent the consensus from just being the loudest, most intimidating voice in the committee room dominating the discourse?
That is where the methodology comes in. First, the snowball sampling. The core committee nominates peers, who nominate other clinical and research experts out in the field.
So it rapidly gathers a wide, geographically and theoretically diverse net of expertise.
Yes. These experts complete detailed web-based surveys. Then the guideline writing group uses the Delphi process.
The Delphi process, how does that work?
Think of Delphi like a highly structured, sequestered jury. It involves a round of open discussion to identify areas of disagreement, followed by blinded, anonymous voting on the proposed recommendation.
Anonymous voting.
Yes. If consensus isn't reached, they review the statistical outliers, discuss the disagreements again, and conduct another round of blinded voting.
Oh, I see. Because the voting is completely anonymous, the halo effect is neutralized. A junior researcher with a valid point cannot be intimidated into silence by an esteemed senior professor.
Spot on. It is systematized democratic wisdom.
So we have the forensic RCT data, and we have the rigorously obtained consensus data for the gaps. Now the committee actually has to draft the rules. And the literature notes that the wording here is treated with microscopic, almost legalistic precision.
Words matter immensely in guidelines. They must be drafted in immediately actionable terms.
Right.
Vague phrasing like, clinicians should monitor for moderate to severe symptoms, is either strictly defined with metrics or eliminated entirely. A clinician needs to know exactly what clinical presentation triggers the recommendation. Furthermore, the specific verbs used mathematically dictate the strength of the directive.
This is central to the GRADE methodology, right?
Yes, grade.
GRADE being grading of recommendations, assessment, development, and evaluation. What do those logic gates look like in practice? How does a clinician distinguish the weight of the verbs?
It boils down to the distinction between a recommendation and a suggestion. In modern APA guidelines, a recommendation is a highly muscular word.
Muscular, how so?
It is only used when the reviewers have high confidence that the benefits of the intervention clearly and substantially outweigh the harms for the vast majority of patients.
And a suggestion.
A suggestion indicates a delicate balance or clinical uncertainty. It means there might be a benefit, but the balance of benefits versus harms is tight, or the underlying evidence is less conclusive.
So it signals to the clinician, proceed, but with heightened vigilance and deeper patient consultation.
Precisely.
So if I am a registrar, how do I actually use this? We now have a scientifically rigorous, bias-checked, meticulously worded set of recommendations spanning hundreds of pages. If I have a packed waiting room and 15 minutes for a medication management consult, how do I actually read this without drowning in text? Let's look at the clinical manifestations, the anatomy of a modern guideline.
If you look at the guidelines published before 2014, they were structurally very different. They had a broad narrative format.
Oh, right.
They offered comprehensive formulation and implementation of a treatment plan. They read essentially it's an exhaustive textbook chapter covering everything from the initial diagnostic interview to checking for early signs of relapse.
They were incredibly thorough, but finding a specific, actionable answer in a crisis was difficult.
Right. It was a dense narrative. You had to hunt for the actual directive.
Yeah.
But post-2014, there was a major format shift driven by grade.
Yeah. Now, guidelines are atomized. They are centered around highly specific, actionable statements that are visually separated and explicitly tied to the strength of the evidence.
Yes. Instead of a 5-page history on the use of lithium, you get a distinct, bolded sentence. The APA recommends the use of lithium for the maintenance treatment of bipolar I disorder, followed immediately by a bracketed evidence rating, like 1A.
It is optimized for the clinical workflow.
Exactly. But it goes significantly deeper than just bolding the text. The modern format explicitly includes highly detailed sections immediately following the recommendation that outline the potential benefits and the potential harms of that specific intervention.
Why do they do that?
The explicit reason for this architecture is to facilitate shared decision-making.
This is a profound paradigm shift. The guideline is no longer just an authoritative manual for the doctor, it's a translation tool for the patient.
It is.
A clinician can literally sit with the patient, open the pocket guide, and say, the highest quality evidence we have suggests this specific treatment has these 3 likely benefits, but carries these 2 specific statistical risks. Based on your life and your values, let's decide together.
Exactly. It structurally embeds informed consent into the architecture of the visit. It democratizes the data.
That's fantastic.
And alongside shared decision-making, the modern format also embeds quality measurement. It includes specific discussions on how a clinic or an electronic health record system, an EHR, can track if the guideline is actually being followed.
Like, can we derive a measurable data point from this recommendation to audit our own systemic performance?
Exactly. That brings an incredible level of institutional accountability.
But before a document with that much power is published and integrated into EHRs nationwide, it must face the review gauntlet. The development process detailed in the texts is frankly exhausting just to read about.
It is an intentionally brutal crucible. Once a draft is prepared, it is distributed to at least 50 selected national and international expert reviewers who were not involved in the writing.
Wow.
But it doesn't stop with psychiatrists. It goes to allied medical specialties like neurology and family medicine. It goes to nursing, psychology, and social work.
And crucially, it goes to patient and family advocacy groups like NAMI, the National Alliance on Mental Illness.
Yes, that is vital. Patient advocacy input ensures the sterile academic guidelines remain grounded in the messy, lived reality of the illness.
Right.
After all those hundreds of comments are systematically addressed, the final drafts must be formally approved by the APA Assembly and the Board of Trustees. Only then does it carry the official imprimatur of the association.
And once it has that authority, dissemination is the final hurdle. I mean, a perfect compass locked in a drawer in Washington, D.C. is useless to a clinic in rural Alaska.
Exactly. So they publish the full monolithic guideline in the American Journal of Psychiatry.
Right.
But they also create tools that actually fit in a white coat pocket. 6 to 8 panel summary guides modeled directly after what the Veterans Administration does. They create patient-family companion guides written in accessible, plain English.
And to ensure the next generation actually reads them, they integrate the content directly into the PRITE, the Psychiatry Residence and Training Examination, and the board certification exams.
Yep. If you put it on the exam, the trainees will learn it. It is the ultimate, inescapable dissemination strategy.
It certainly works. So the guidelines are rigorously engineered, they are disseminated, they are memorized for the boards. But here is where we hit the real world. When the clinician sits across from a real, complex human being, when Arthur is sitting in the chair, what are the actual benefits of this system, and where does the compass begin to fail? Let's move into integration and clinical reasoning, where the art of psychiatry meets the science.
Let's start with the triumphs, the clear systemic advantages of integrating guidelines into clinical practice. The most significant macro-level impact is the reduction of unwarranted geographic variation.
Ah, the postcode lottery?
Exactly.
Right.
Without standardization, the quality and type of care you receive is heavily dependent on your postcode and the idiosyncratic habits of the local physician.
Right.
Studies have shown wild, unacceptable geographic variations in hospitalization rates, the use of high-dose antipsychotics, and tragically, even death rates due to depression or schizophrenia. Standardized, evidence-based guidelines smooth out those variations. They establish a scientifically validated floor for clinical care globally.
They democratize good medicine? What about the financial and social impacts?
They are massive. Guidelines dictate third-party payer reimbursements. They provide the irrefutable medical and legal ammunition for a clinician to say to an insurance company, this specific treatment is backed by rigorous high-strength evidence. You are medically obligated to cover it.
That is huge.
And conversely, they identify ineffective or obsolete treatments that should be dropped from formularies. And on a broader societal level, guidelines actively reduce the stigma of mental illness.
By codifying the pathology.
Yes. By legally, medically, and scientifically demonstrating that mental illnesses are real, discrete, diagnosable, and treatable physiological and psychological conditions with specific, validated interventions.
A 200-page evidence-based guideline legitimizes the suffering of the patient in the eyes of society, employers, and policymakers.
Spot on.
Those are massive systemic triumphs. But let's look at the friction, the limitations, because the literature highlights a reality that every single clinician faces, and it's a reality that threatens to break the compass entirely. The core problem: guidelines are fundamentally written for single illnesses.
Yes. The architecture is siloed.
Yeah.
You have a pristine guideline for major depressive disorder. You have a separate guideline for substance use disorders.
Right.
But the epidemiological reality is stark. At least 50% of psychiatric patients have more than one psychiatric diagnosis. And that is not even mentioning the staggering rates of physical medical comorbidities, diabetes, hypertension, metabolic syndrome.
Which brings us right back to our hook with Arthur: severe depression, severe alcohol use disorder, cardiovascular disease.
Exactly.
If I blindly follow the independent guideline for depression, it might recommend a medication that is heavily metabolized by the liver. But the alcohol guideline notes his liver is compromised. And the medication might have a side effect of prolonging the QTC interval, which violates the cardiologist's guideline for his heart.
Yep.
Following the guidelines exactly as written results in a mathematical contradiction.
And this is exactly where the art of psychiatry operates.
Yeah.
This is the very definition of clinical reasoning.
Right.
Guidelines, by their nature, cannot account for the infinite permutations of human comorbidity. The clinician must synthesize the various guidelines, calculate the overlapping pharmacokinetic contraindications, evaluate the patient's acute physiological state, and prioritize based on triage.
Which fire is burning hottest?
Exactly. What are the patient's immediate values and goals? The compass gives you the correct headings for the various destinations, but you, the clinician, have to chart the safe route through the mountains.
This directly addresses the elephant in the room: the fear of cookbook medicine and malpractice. Clinicians fear that guidelines enforce a reductionist view of humanity, and there is a darker, more pragmatic fear: the fear that guidelines act as a weapon for malpractice lawyers.
Right.
The fear is that a lawyer will stand up in court and say, Dr. Smith, you did not follow Step 3, Algorithm B of the APA cookbook, therefore you are negligent.
It is a very pervasive anxiety, but the legal data provides a strong counter-narrative. Empirical studies of medical jurisprudence show that clinical practice guidelines are actually used equally by defendants, the doctors defending their care, and plaintiffs, the patients suing.
Really?
Yes. And crucially, the introduction of guidelines has not increased the overall success rate or severity of malpractice claims against psychiatrists.
Why is that? Why hasn't it become the ultimate legal weapon?
Because of how they are explicitly written and legally recognized. They are recognized as guidelines, not standards of care.
What's the legal difference?
A standard of care is a rigid legal threshold. A guideline is a navigational tool. The preambles to these guidelines explicitly state that the recommendations must be considered by the physician, but ultimate decisions must be based on the unique needs of the individual patient. If a doctor documents in the chart, I am intentionally deviating from the primary guideline recommendation for this antidepressant because the patient has a severe cardiovascular comorbidity and a cultural preference for non-pharmacological intervention. That is not malpractice.
That is the documentation of exemplary, highly individualized clinical reasoning.
Exactly. The legal defense is the documentation of your reasoning.
So the defense is doing the maths and showing your work. But even without the fear of malpractice, the literature notes that physicians often simply don't use the guidelines. There is a famous framework by researcher M.D. Cabana who identified 6 primary cascading barriers to physician implementation. Can we dive deep into Cabana's framework?
Absolutely. Cabana's 6 barriers are fascinating because they move sequentially from simple cognitive deficits to deep psychological resistance.
Okay, what's first?
First is lack of awareness. The clinician simply doesn't know the new updated guideline exists. They're busy, they aren't reading the journals.
Fair enough.
Second is lack of familiarity. They know the new guideline was published, but it's 200 pages long, and they haven't had the time to read the details to know how to actually apply the logic gates.
Those first 2 are just information bottlenecks, but the next ones are much harder to solve.
Yes. Third is lack of agreement. The clinician reads the guideline, understands it, but fundamentally disagrees with its interpretation of the evidence. They might feel the committee overvalued a specific set of RCTs and undervalued clinical experience.
What's the fourth?
Fourth is lack of self-efficacy. This is crucial. The clinician agrees with the guideline, but doesn't feel they possess the training or skills to execute the recommended intervention.
Like what?
For example, if a guideline strongly recommends specific trauma-focused cognitive behavioral therapy, but the clinician was only ever trained in supportive psychopharmacology, they literally cannot implement the guideline.
That makes total sense. And the fifth?
Fifth is lack of outcome expectancy. The clinician understands the intervention, but they are deeply cynical. They don't believe that following the sterile guideline will actually result in a better outcome for their specific, highly complex, socioeconomically disadvantaged patient population compared to whatever they are already doing.
Right. And the sixth barrier?
The most profoundly human barrier of all, inertia of previous practice.
And
let's look at Dr. Y. Dr. Y has been prescribing a specific combination of older medications for 20 years. It usually works okay. To change his practice based on a new guideline requires changing his EHR templates, altering his 15-minute workflow, having longer conversations with patients about side effects, and facing the cognitive friction of learning a new system.
it is simply too exhausting. The inertia wins.
Precisely.
That inertia is a powerful gravitational force. Overcoming Cabana's barriers requires so much more than just mailing out a PDF booklet. You need multifaceted, systemic interventions, integrating subtle, non-intrusive prompts into the electronic health record,
Right.
using respected local opinion leaders in clinics to champion the changes, and actively educating patients so they walk into the clinic and actively ask for the guideline concordant care.
Exactly. It requires a cultural shift, not just an information dump. And there's one final existential barrier to implementation that the field is currently grappling with: the updating crisis.
The speed of science.
Precisely. It takes approximately 2 to 3 years of exhaustive committee work to write a comprehensive guideline. They are intended to be updated every 3 to 5 years.
But the scientific literature is moving at an unprecedented velocity.
Yes. By the time a massive, all-encompassing guideline on bipolar disorder goes through the review gauntlet and is published, a landmark trial regarding a specific new antipsychotic might already be published. That renders a portion of the brand new guideline instantly obsolete.
So how do we fix that? We can't tell clinicians to navigate with a compass that is 3 years out of calibration.
The future horizon involves a radical shift toward targeted informatics and living documents. Instead of rewriting an entire 300-page monolithic document every 5 years, developers are beginning to use informatics algorithms to continuously scrape databases like Medline for new, high-quality RCTs.
Oh, wow.
When statistically significant new evidence emerges regarding one specific discrete treatment, the committee convenes rapidly to update just that single node within the digital guideline. It is moving from a static textbook model to a dynamic, continuously updating, living digital ecosystem.
That is a brilliant transition into our key takeaways. We've covered a massive amount of clinical and methodological ground here, tracing the engineering of this compass from the Kirkbride asylums of 1851 to the digital algorithms of today. Let's distill this into the critical concepts for our listeners.
Let's focus on 5 core takeaways. Number 1, practice guidelines are navigational tools compasses, not railway tracks. They provide structured, evidence-based recommendations to support and anchor clinical judgment, but they are never meant to replace it.
Absolutely. Number 2, trust requires transparency. Modern guideline development demands rigorous grading of bias and evidence-utilizing frameworks like the GRADE methodology and the draconian management of conflicts of interest, meaning absolutely zero industry funding.
Takeaway number 3. Because psychiatric research faces profound, unique obstacles, especially regarding the near impossibility of running long-term RCTs on complex psychotherapies, rigorous snowball expert consensus and sequestered Delphi voting are vital. They are methodologically valid mechanisms for filling the clinical gaps where empirical trial data cannot exist.
Takeaway number 4. Standardization decreases unwarranted geographic variation, fights the postcode lottery, and actively reduces stigma by legally and medically proving the efficacy of our treatments. But clinicians must constantly remain vigilant against algorithmic reductionism.
And takeaway number 5, perhaps the most important for daily clinical practice, the 50% rule. Over half of psychiatric patients present with multimorbidities. Therefore, your clinical reasoning must always transcend the siloed guideline. You must synthesize the data with the unique physiological, psychological, and social realities of the specific human being sitting in front of you.
Excellent. Now, to truly cement these mental models, we are going to transition into our learning reinforcement. I have 6 single best answer style scenarios drawn directly from the concepts we've just unpacked.
Right, let's do this.
Let's run this as a series of clinical thought experiments. I'll pose the scenario, I'll take a guess at the most intuitive, perhaps slightly flawed answer, and I want you, the listener, to think about what you would do. Then our expert will correct us and unpack the logic. Are you ready?
Ready.
Let's start with question 1, focusing on the core concept. Imagine you were explaining the primary purpose of clinical practice guidelines to a skeptical first-year medical student. Which of the following is the most accurate description? A, to establish absolute legal standards of care. B, to replace clinical judgment with algorithms. C, to assist decision-making by summarizing evidence-based strategies. Or D, to ensure reimbursement for all new pharmaceuticals.
Okay, what's your instinct here?
Well, my instinct, playing the cynical doctor, is to lean towards A or D. It feels like these are just legal shields or insurance mandates.
It is a common cynicism, but the correct answer is unequivocally C. Guidelines exist specifically to assist decision-making by summarizing evidence-based strategies.
Yeah.
They're explicitly not legal standards of care. Deviating from them with good clinical reasoning is entirely permissible. They do not replace clinical judgment, they inform it. And they frequently recommend against reimbursing ineffective pharmaceuticals.
Perfect. Question 2, let's look at the mechanism of development. During the development of an APA practice guideline, why is the snowball sampling methodology explicitly utilized by the committee? A, to gather patient feedback on side effects. B, to identify clinical and research experts to provide consensus when rigorous clinical trials are not possible. C, to increase the number of RCTs in the literature search. Or D, to secure funding from allied medical organizations.
Your thoughts?
I might guess A, because we talked about patient advocacy groups being involved.
Patient advocacy is involved in the review process, but the snowball sampling specifically refers to B. It is the mechanism where peers nominate peers to build a diverse pool of clinical and research experts. This pool provides the structured consensus necessary to fill the vital evidence gaps where randomized controlled trials are impossible or unethical to conduct, like taking a patient history.
Question 3, diving into grade. According to the post-2014 formatting and grade methodology, what determines whether a statement is categorized as a strong recommendation rather than a weaker suggestion? A, the intervention is inexpensive. B, the intervention is supported exclusively by double-blind RCTs. C, there is confidence that the benefits of the intervention clearly outweigh the harms. Or D, the intervention has been approved by the Institute of Medicine.
A lot of people get tripped up by this one.
Yeah, I would assume it's B. If it's a recommendation, it must have massive double-blind RCTs behind it.
That is a very common trap. But the answer is actually C. Under the grade framework, a recommendation is a strong directive used when the committee has high confidence that the benefits clearly and substantially outweigh the harms. While RCTs often inform this, strong unanimous expert consensus can also drive a recommendation in areas where RCTs can't exist. It is about the balance of benefit versus harm, not just the presence of a specific trial type.
Question 4, bringing in clinical reasoning and comorbidity. A psychiatrist is treating our patient Arthur, who presents with both severe depression and a substance use disorder. A major limitation of applying standard practice guidelines to Arthur is, well, which of the following? A, guidelines legally prohibit treating more than one disorder at a time. B, most guidelines are single illness focused, and there is limited evidence on simultaneous treatment of comorbidities. C, insurance will only reimburse the treatment of the primary diagnosis. Or D, guidelines for depression do not allow for psychosocial interventions.
What do you think?
I know A is ridiculous, so I'll go with B.
You are correct. The answer is B. This is the crux of the comorbidity problem. Guidelines are generally written in disease-specific silos, but over 50% of patients present with multiple conditions. The limitation is the stark lack of empirical evidence on how to simultaneously navigate overlapping, sometimes contradictory, guideline recommendations. This is where algorithmic medicine fails, and the clinician's art is fundamentally required.
Question 5, an application of Cabana's barriers. Imagine Dr. Y. Dr. Y knows about the new guideline, understands the logic, but continues to use an older, less effective treatment regimen simply because, it's how I've always done it and changing my EHR templates is a nightmare. Dr. Y is primarily exhibiting A, lack of outcome expectancy, B, lack of self-efficacy, C, inertia of previous practice, or D, lack of agreement.
That is a textbook presentation of C, the inertia of previous practice. Dr. Y is not doubting the outcome, they are not disagreeing with the data, and they aren't lacking the skill to write a new prescription. They are simply succumbing to the powerful psychological and administrative friction of changing an established decades-old workflow.
And our final scenario, question 6, looking at legal application. You are the clinician. You intentionally alter a treatment plan away from a specific guideline recommendation due to a patient's unique cultural context and their severe cardiovascular comorbidities. Regarding malpractice liability, you should understand that. A, deviating from the guideline guarantees a successful malpractice claim. B, guidelines are legally binding standards of care. C, guidelines are intended to inform, not dictate care, and individual patient circumstances justify clinical deviation. Or D, the clinician must obtain APA approval before deviating.
The answer, which every clinician should internalize, is absolutely C. Guidelines are compasses, not railway tracks. They inform care. If you document your clinical reasoning for deviating based on the specific unique physiological or psychosocial needs of the patient sitting in front of you, you are practicing excellent, defensible medicine, not committing malpractice.
Brilliant. I highly direct you, the listener, back to Chapter 7.3 of Kaplan and Sadox to review the granular details we discussed, especially the methodological logic gates of the grade system, in full detail alongside your practice.
It's an essential read.
Now, to close our deep dive, I want to leave you with a final provocative thought to mull over as you head into the clinic. As electronic health records become increasingly integrated with artificial intelligence, we are rapidly moving toward a future where practice guidelines might not just be static digital documents we reference, but dynamic, generative algorithms operating quietly in the background at the point of care.
It's fascinating to think about.
Right. Imagine an AI instantly cross-referencing Arthur's exact genetic profile, his liver enzymes, his 3 active comorbidities, and his real-time wearable cardiovascular data against the entire global database of clinical literature to generate a hyper-personalized, statistically optimized treatment path in 3 seconds.
That would be revolutionary.
But will this ultimate dynamic AI-driven compass finally solve the comorbidity problem that plagues modern psychiatry? Or will it become so complex, so fast, and so legally authoritative that it subtly forces clinicians back onto the rigid railway tracks of algorithmic medicine, slowly stripping away the very human, intuitive art of clinical reasoning? It is a profound, perhaps existential question that the next generation of psychiatrists will have to answer.
Indeed they will.
Here are the details of this episode.
Practice guidelines in psychiatry.
Right.
Byline. Good clinical judgment begins with wisdom, but it is strengthened by evidence.